Welcome, everybody. Welcome to Logista's Preparedness Partners webinar series with a new series called Big Ideas. And we have Mark Keim with us today to kick it off with the first Big Ideas webinar. And where this kind of came from is at Logista, Logista came out of an idea of a big idea was how could we do rapidly deployable logistics systems and create a universal standard for disaster logistics. And as we were going through and having hundreds of conversations, it was feedback from other people, feedback from other professionals, feedback from a lot of you we've had conversations with that was super helpful in refining that, evolving how we were approaching stuff. And we wanted to give a platform for other people who are having really big ideas in this space so that they can share that ideas with other folks and get some feedback as well. It's that dialogue that we found really, really helpful of pushing ideas out, getting feedback, adjusting, and evolving. So with that note, I'm going to pass it over to my brother and co-founder in Logista, Drew Downing, and he's going to kick things off for us here.
Thanks, E. Yeah, really excited. Dr. Mark Keim is joining us. I'm excited for this one. I think it's coming at a pivotal, it's always needed, but it's coming at a pivotal time where there's a juncture in what we're doing and there's opportunity in what we're doing. There's opportunity to re-examine of how we're doing stuff, strategy, tactics. So first, going to give you just a quick background of Mark's System Division Director at Fairfax County Health Department in Virginia. Background, disaster medicine and public health emergencies. He was also at the CDC for a while, being the Associate Director for Science, had his hand in Katrina, anthrax attacks. He's been in over 50 publications, anything from climate and health research with the UN and the U.S. government. He's also at Emory and Harvard, different programs there, having a hand in helping teach and push things forward there. So, Mark, really excited to hear more about this. I read it when you shared it with me multiple times. I passed it forward to other people. So I'm excited to get more context. And as people have questions, feel free to put them in the chat. Maybe we can save some and I can throw some at you. But I'll kick it over to you. And if anything strikes me too, I may just interrupt you if I have a question that I can't wait for.
Sounds good, bud. Appreciate that. Okay. Thanks, Kai. All right, so welcome everyone, and thanks Drew and Ethan for the opportunity to talk with everyone today, and thanks for everyone for taking the time out of your Friday to come join us. And I want to start off with the typical disclaimer: the views that I'm about to share with you are personally my own personal views and don't reflect the perspective or the policies of Fairfax County government or the health department of where I work. So this is Mark's ideas and trying to make them as big as we possibly can with one little guy. So just take that with a grain of salt. I'm going to talk to you today about the need for a national strategy to assess and reduce disaster-related mortality in the United States. And so that's a long sense for basically saying, let's get our acts together and let's start talking about a strategy for once. And so I want to talk to you a little bit about how I came upon this idea, what happened to me in my life that got me involved in this kind of stuff, and then why actually this is probably the only way forward if we're ever going to make a difference in actual health related to disasters. You know, everybody says build back better. When you can do that with a human being, you let me know. Because that's the problem with Build Back Better and mitigation and all this is you kill a human, it's really hard to show up 3 days later and say, we're here to help. And it doesn't help the family that much when you say, gosh, if they'd only been here when we got here. So I think what you're going to see is the first perspective that I'm going to share with you is actually my perspective as a victim. And coming from that, then what I want is effective. I want things to be actually working and saving lives, not the number of tarps and the number of pounds of ice that we've delivered. So to start off, actually, while I'm doing this, I think I could at least provide some context while I'm waiting for this to come through. So I started off, actually, my interest in disasters began rather abruptly at 316 on May 29th. Actually, what a day. Look at the date today, right? May 29th, 1982 at 3:16 p.m. when I became interested in disasters as a disaster victim. And that's when a disaster actually went down my Illinois. An F5 tornado went down into my community, displaced over 1,500 families, and killed about, I think it was 13 to 15 people. So remarkable event. I was 20 years old at the time. I was a medical student I was actually pre-med in undergrad and had to drop out of school in my sophomore year and spent years outside of school as a disaster victim. And so there was some lessons that I learned in that event, and I wanted to share. So basically, I'd shared with you my story about being in that tornado. And actually, how did I know to survive that tornado when a tornado came down my alley or down my street? Basically, it was because of a book that I read when I was 7 years old. And it was in an old publication called The Weekly Reader. And Weekly Readers were actually a newsletter that was made for children that put out information written at your reading level. And my mom, we've never had much money, but my mom was always a soft touch for buying me books. And so I talked her into buying me one of these $1 or $2 dollar little books, and I read that about tornadoes from cover to cover. And I learned how fast they go and how big they are and so on, and all these different things about tornadoes as a little boy. And then now fast forward 15 years later, and Drew, can you advance the slide for me, please? So 15 years later, I was living in Marion, Illinois, in Southern Illinois, and I was going to a pre-med at the time and working part-time and working my way through college. And next slide, please. And Memorial Day weekend, unseasonably warm weekend. Here we are approaching Memorial Day weekend, ourselves as well, right? There we were, unseasonably warm, very hot, and next thing we know, we start having these sirens going off. My wife and I walked out to the front yard, looked at the street, and lo and behold, in that picture prior to here, we had actually a tornado right there in front of us. And we saw that tornado starting to come across the street. And actually, you can see in this photograph, there's a little explosion sign there. That's where my home was. And this was the path of the tornado, right dead alley, right down my street. And you can see that I actually got in the car and moved out of the way. And why did I do that? Because I had no basement in my home. And I had pulled a kitchen table into the center of the home and put my wife underneath it. And I ran across the street to see if my neighbors were home. And when none of them were home, I even thought about, gosh, should I break in their door? Because I knew they had a basement that was safe. How did I know that the basement was the safest place? That book that I read when I was 7 years old. And then I started running across I decided not to break in their door, of course, because of course, nothing is going to ever happen to me. That's what we all believe, right? I ran across the street, and that's when I saw that tornado hitting at the end of East Plaza and coming in across to my street. And I could see it hit a brick schoolhouse and eat the top of that brick schoolhouse off. And the bricks came down, raining on both sides. And it was then I realized, we're not going to survive in this little wooden structure that has no basement. I ran back in. I grabbed my wife, and we got in the car, and we turned and went down the street you can see here. And then I turned at a right angle, and I headed due north, and I knew that I could get out of that tornado's path and it would not turn and come get me. How did I know that? A $2 children's book that I read when I was 7 years old. And so I drove out of its way, and I drove back, and then that's when I saw the destruction. And to be honest with you, for 30 minutes, I couldn't even find my house because the destruction was so remarkable. So I learned a lot of that day. And one of the things I learned was, number one, if you don't have your health, you don't have much. So I learned that at 20 years old. Also, my family. I learned that if you don't have your family, if you lose your family, these kinds of things, you've lost a lot. And the other thing that I learned that I wanted to share with you, a $2 children's book saved my life and saved my wife's life as well. And that's the lesson that I carried on for the rest of my life. Next slide, please. So there's what my house looked like in the after picture. And if you notice, that house is actually sitting on a driveway. It picked up the house, took everything apart, and slammed it back down on the driveway. My wife and I would have been in the middle of that debris or somewhere down the street. Surely we both would have been killed in that example. So there's a good lesson to learn. And I learned more after that as well. Next slide. And so one of the things interesting was when I got to CDC, I met a guy named Roy Ing, and he had actually written a study about this particular tornado. And one of the things that was really impressive about this was all deaths occurred during the impact phase. So what does that mean? There's pre-impact before the disaster. That's when we could hear the warnings and things. There's impact when it's actually happening. And then there's post-impact afterwards. And what we know now is that in most disasters that involve environmental emergencies like this one, Most of those disasters, people die in the first 1 to 3 hours because they're hit by injuries. And in injuries, if you receive a traumatic injury of the level that can take your life, you have about 1 to 3 hours, most of the time, actually 50%, 1 hour to get not only to the emergency department, to get to a surgeon, to get in the hospital room, surgery suite itself. So you can imagine that's a difficult thing on a normal day in America, but let alone trying to do it when the ground's still shaking, the debris is all in the streets, or the area is still flooded. So the idea that we can actually make it there during the impact phase, actually what we find is 80% of people die during the first several hours of a disaster before the state, before the federal government. It's you and it's your neighbors. So if it all happens during the impact phase when we can't get to you, when can we help? We have to start thinking beforehand. We have to start thinking about prevention. So next slide, please. So I spent a career after that. We got into medical school. I was out for 5 years, actually went back to medical school, became an emergency physician and subspecialized in disaster medicine. And then I got fortunate and was picked up by CDC, and they sent me all the way around the world. You can see in different places, in tsunamis, hurricanes, sea level rise events, hazmat, those kinds of responses all over the world. And I was able to see that actually reinforced the lessons that I had learned that day about the importance of low tech, high evidence-based interventions like we're going to talk about today. And that really got me started in thinking, why can't we have a national strategy for doing this in a better way? And next slide, please. And so here, over that period of time, climate disasters have been increasing worldwide. Here's a study that I did a few years back looking at disasters for climate-related disasters from 1969 to 2018. And you can see it's when we follow that mean, that line, that the trend line there, that blue line, straight up in a pretty steep way. So we know that the disasters are increasing. Next slide. And they're also becoming more severe as well. So double whammy. We all know that this is coming. Now, when I made these slides, I didn't realize we would also be basically disintegrating as an emergency response unit and pushing many of those kinds of capabilities aside. But we can already see we're facing the problems that are going to be increasing over a period of time. So I started thinking about it. If we're going to have increasing levels of disasters over the next 200 years, what should we be thinking about in a 200-year approach? More ambulances? More hospitals, or should we be thinking about reducing the risk of being exposed to begin with? And so that's where I start getting the interest in this area. You can see that over a period of time, what we've been doing in the past, it hasn't been working. This is a study looking at a long stretch of period of time in the United States, 1967 to 2016, and there was no significant change in the U.S. disaster mortality rate. That's taking into consideration the number of people that were increasing in the United States as well. And that average of that line is actually, there's a few go up and a few down, but the average is actually relatively flat, actually very flat. So there's no significant change. Now, in the meantime, we did the Stafford Act, we did the PAPA 1, PAPA 2, the Bioterrorism Preparedness Program, all of those hundreds of millions, billions of dollars being spent, and we're not making a difference in public health. And why is that the case? Once again, you have to look at the timing of the deaths and what we're really trying to achieve. Next slide. So there's this myth of resilience. And like I talked about, people say, oh, well, you need to be resilient. Well, what's resilient mean when I've just been hit or had my severe injury from one of these disasters? And this is what I was referring to before. You can see that 80% of these injuries, these deaths that actually occur in the first 50% in the first hour, and then 80% in the first few hours. They call that the golden hour. So those folks out there that are listening to this now, you and EMS and emergency medicine recognize that golden hour, and it goes all the way back years ago, but it's still our problem when it comes to disasters. Next slide. So even if you have all this resources coming together, here's a slide that shows you that every single time it's too little, too late. People talk and argue, they politicize, they go back and forth about how they're going to help you, who's going to help. And in the Indian Ocean tsunami, countries argued about who would help. And so in the meantime, needless delays, frustration, on and on. People talk about those terms. I'm frustrated with the fact that what we have is people are already dead. And we're no longer even counting those numbers. And so so that's the big problem here. That's not public health. That is something completely different. And so what I'd like to be is to do something that public health can do. The main thing that we have been suffering on is this slide shows U.S. federal assistance and contracts over a period of time of about 8 years, up and then down. And then also, who are we funding? I mean, you can see the majority of the funding here actually went to emergency management and engineering, and very little goes to public health, actually. And you're talking about a pittance of research dollars when you compare it to other areas like cardiac disease, chronic diseases, and so on. So we're really not spending anything in public health as far as the research itself that would guide what we should be doing. We're just doing the same thing over and over and over again. Next slide. And so the current approach is basically reactive 19th century style approaches. It's rarely preventive. It's going in after the fact and trying to cure the injuries and illnesses of people that have already been exposed. It mistakenly treats natural disasters like outbreaks, where you have a few cases, you get in there, you take care of those cases, and you stop the thing from involving a large number of people, because you have what's called an incubation period where the disease takes a while to accumulate. Of course, in injuries, when you hit on the head with a big old brick, you feel that pain right away and you have that injury immediately. So the idea that you could treat a natural disaster that has these injuries, like an infectious disease outbreak that would have infections, two different things, two different windows of opportunity. In addition, no federal agency really has a mandate to actually reduce disaster-related deaths. Now, some of you are going to be surprised to even find out that no one even has a mandate on the federal level to even measure disaster-related deaths. In order for CDC, when I was there, to actually come and help a state to look at what the measurements are of how number of people, the state would have to place the request. And if the state did, CDC wouldn't go. And so you have these events occurring in states that had good capacity where we wouldn't have any data whatsoever. And the next year, we have no trend analysis. We don't conduct timely, transparent investigations. It's asking for it, rounding up the people and sending it. And certainly those don't drive policy recommendations. They usually involve recommendations for individuals. So what we have is basically a situation where federal and academic institutions really have no incentive to measure the effectiveness of their own outcomes and draw attention to that fact, or to question funding that's not linked to impact. Who in their right mind would say, can you hold me to a higher standard instead? And you just don't hear that often. So in the next slide. So that's one of the problems that we're facing in our current approach. And the difficulty is when you actually look at what causes disaster deaths, it's only three things. It's the vulnerability of the person. In other words, their risk factors. It's the exposure to the event, to whatever hazard it is, and it's the environment that exposure occurs. And if you separate that out, for example, take people away from the exposure, like an evacuation, then they cannot be killed by that tornado or that flood or that hurricane. So the real issue is location, location, location. Most disaster deaths can be prevented because if it's predictable, it's preventable. But what we've done in place of that is we've followed just like medicine did, starting with the cure and then realizing later on down the line, wait a minute, let's start vaccinating people instead of treating them for those diseases. Let's start preventing injuries instead of treating people in those ways, prevent burns and so on. So we've done that in other areas. We just have not carried that same logical approach to disasters. And that's what I'm calling about when we start talking about reorganizing. Don't tell me what you're going to tear down. Tell me what you're going to put into place to make these deaths go down. Next slide, please. And so why do I think this might work? Because we've been doing it and we've done it exceptionally well over the past 50 years. It's remarkable to understand the 1969 National Highway Transportation Safety Act and its impact on U.S. mortality rate. And here you can see that during right before the 40s, you can see that transportation deaths really peaked in the United States, and then it lowered down because of World War II. And then as soon as it got over with, it started climbing again. In 1969, folks said, let's do this National Highway Transportation Safety Act. And what does that mean? Basically, it took a comprehensive approach. It not only worked with ambulances, improving those and improving hospitals and the capabilities there, but it also moved upstream to those causes of the cause. So, for example, making highways safer, that's where your driver's education programs actually started in the United States. Seat belts, collapsible car frameworks, all of those things started with the National Highway Transportation Safety Act in 1969. Since that period of time, actually, this act has been called one of the top 10 public health accomplishments of the 20th century. And the way it happened was Congress. Now, wait a minute. Let me get my head around that. Hold on. Wait, what's the next slide, please? So Congress actually saved more lives than all of medicine and nursing ever could. I never thought I'd say those words, but actually, gosh, isn't that something? And actually, it's continued to go down to this day. It's still going down. So it's remarkable accomplishments. So you say, Dr. Keim, how could we ever do this? Actually, it's been done, and we did it really effectively, and we did it as a nation when we recognize that. So when these costs get high enough where we're really considering actually lowering morbidity and mortality, this is the approach that I would recommend us try. And that's why we've been actually pushing this over quite a period of time. Next slide, please. So there's two reasons behind this. One of them is they had the act that said there has to be established a goal in measurable health outcomes. Can I get that across to someone else outside of public health? That the way you measure success at FEMA can also be measuring the outcome of whether people live or die, not the number of tarps, not the number of tents, not the pounds of ice. And I know I'm oversimplifying that, and I don't want to get to be too harsh on FEMA. I am a big fan, folks. I'm a big, big fan. But this shows you that actually measurable health outcomes can make a difference. It can be a different situation here. The other piece of it is that there was a safety board. So in 66, they had this new act, and then deaths didn't go down right away. So they put a safety board into effect that had teeth that said, yes, we will actually review these issues and we'll start making recommendations. And then they put an administration in place that would actually regulate it. And so that's why when your plane actually has a problem and a plane goes down, we actually have this safety board review that with subject matter experts and engineers, find the cause, and then make recommendations, and then the policy gets put into place where the plane changes. So now you're flying on planes that actually have a turn like this, where the wing comes up like this. That's because of one investigation that found that there was cross turbulence, and they went to found it was the plane wings and said in the future planes need to change the shape of their wings so that this disaster won't happen again. Now, I want to point out that actually Miguel Cruz is in the audience right now, and Miguel and I were involved in a situation where Alabama, where there was an outbreak of tornadoes that occurred there. And I can remember walking in that morning with Miguel and actually and hearing him say, did you hear what happened in Alabama? This many hundreds of deaths, And so we got there to work, and we were like asking the people that were doing the studies, hey, what was the cause of this? And they're like, well, we're not looking. We said, what? 200 Americans died a day? And we're not looking at the cause? Oh, we know what causes people to die in tornadoes. Yeah, but what causes them to die in this one? And how can we stop that from happening? 200 people, that hasn't happened in a long, long time. And so those are the kinds of issues that we addressed, and we did that a long time ago when both of us had a lot more hair. So you can imagine we've been pounding this out and trying to get the people to change their mind over this. So next slide, please. And so, what we saw after Hurricane Maria in Puerto Rico is they weren't even going for an accurate accounting of the deaths. And so I actually wrote letters to Congress at that time and was calling for an accurate accounting, and went to 15 congressional offices here on the Hill and actually met with them individually and promoted this idea. And we got a lot of responses from those that were positive. But once again, it's the inertia that we're still doing the same thing the same way over and over again. Next slide, please. And so we actually went together, public health leaders, the executive director of the American Public Health Association, the director at the time of the Uniformed Services University of Health Sciences Center for Disaster and Humanitarian Assistance. Many of the leaders of public health, about a half dozen or so, got together and wrote this particular article that was then published by APHA. And basically what it called for is A, B, and C in a three-part strategy. One, establish a national disaster safety administration that will develop and enforce national standards, like that Highway Transportation Safety Administration. In addition, a national disaster safety board of subject matter experts that's independent and transparent. Investigations of disaster-related mortality that have to occur regardless of declaration. And third, a center for disaster statistics. There's too much information floating around in everybody's individual pieces. This needs public access to a sustainable national database of disaster-related data that all of us can achieve, and there's transparency in that message. So that's one of the things that we really are calling for. You can see now that this has been fleshed out. We've even written a draft bill that's gone through. As a matter of fact, I just want to point out that your former Vice President of the United States saw this in her office when she was still a senator. But once again, we're in different times and we're in different modes. So I don't see these things as political. I see them as a basic fundamental right to health. And that's what we need to be able to help people with. And we're heading down the wrong direction if we think we can arrive later than 3 hours. If you can get there in 3 hours, you let me know. I'd be more than happy to go with you. Next slide. So what we have to do is, like to say, we've got to move to the left of the bang. And so this is called the natural history of disease. And you have this on the far left, this stage of susceptibility that we all have. And then you have some exposure, fire, explosion, chemical weapons, tornado, high winds, flooding. And then you have this substage of clinical disease where these changes actually occur. And then disease comes on. And the trouble with an injury, like I mentioned before, is that first stage is just seconds to minutes before you're in the golden hour. And you've got to get out of that. So we have to start thinking about upstream, moving to the left of the bang. And that's what I want you to have the take-home message today. Move to the left of the bang. Next slide. And so, say, hey, Dr. Keim, great, worked with National Highway Transportation Safety Act, but what about disasters? How do you really know it's going to work? Well, it's worked with tornadoes, luckily. And the reason why is because of less exposure. It's less exposure because of improved forecasting and early warning, improved communication. You're carrying your messages in your phone now instead of on television or some sort of broadcasting radio. And there have been changes in construction of good old mitigation. And so what we've seen here is that deaths per million people of tornado deaths are decreasing, just like what we saw in the National Highway Transportation Act. And is this because public health response? No. Blasphemy, right? Whoa, wait a minute, hold on. Wait, funding. No, let's be effective. Let's link funding to the effectiveness of the interventions that you have. In other words, let's link funding to health outcomes. That's my recommendation, or what that should look like. Next slide, please. And so I propose a National Disaster Safety Act, as I mentioned, A, B, and C, as I went through before, mandating a measurable outcome, a reduction in disaster-related mortality. Now, let me turn you on to something. Years ago, back in 2015, we actually signed an agreement that was international over the next 15 years. The United States committed among over 100 countries in Japan that we would actually reduce disaster-related mortality. We signed that agreement in 2015. A lot of countries signed it, and a lot of countries came back home and did something about it. And I got to tell you, in my opinion, I'm looking around, I don't see a whole lot of reduction in disaster-related mortality, nor are you hearing a lot about that programmatic commitment that we made. Probably not, right? We're talking about moving things in a completely different direction than what our international agreements actually recommend. So recently I posted on LinkedIn, actually the rest of the world doesn't have a whole lot of confusion about what their point is going to be forward in disasters. It's this model, and it's going to go until 2030. They signed the agreement in 2015 for a 15-year process, all overseen and worked through with multiple organizations as well as the United Nations. Next slide. So finally, I just want to say thank you. I think we're got a little bit of extra time. If folks can pop in as well, and more than happy to take any questions as you see, Drew, whatever you feel to be able to move on. Turning it back to you.
Mark, I got one off the top of my head that I think is like probably an emotional reaction that people in our industry get, and it goes back to your blasphemy.
Yeah.
All this energy goes into response. We're coordinating a response, even certain preparedness efforts. And that's where our focus, that's where the funding's been. What do you say when I say, what do you mean the response isn't saving lives and that energy there that's invested there isn't worthwhile?
Well, I showed you the study where we looking at that over 20 years. I also have another study looking at over disaster-related deaths in the United States over 50 years. I've also had another study looking at disaster-related deaths on a worldwide scale. And the reality is that people just, you can't get to them. So the reality is we're not making any difference whatsoever. So that's the bottom line, is that if it were working, I would say great, but it's not. And so we really aren't getting to people in that period of time. And so we need to be thinking about this. There's an example, actually. Fire is a good example of how we've overcome that. So in the 1950s, fire was an increasing problem throughout into the 1960s as well. We had the Vietnam War, and we had a remarkable increase in our ability to be able to manage fire burns in particular. And that expertise came back over to the United States after the war and started developing in these burn centers. And it really didn't get off the ground a whole lot until people started realizing one of the fundamental problems: we weren't making a difference in mortality. And let me give you an example. So you see these old white hairs on my head. When I was a kid, a medical student in there, and they were teaching me about burns, they said, if you have a 50% burn on your body, you have a 50% chance of dying, 70% chance of dying, and so on. That hasn't changed, Drew. It hasn't changed. I'm an old man. And so that was not the problem. So what did people do? They put a lot of money into burn centers, burn nurses, burn units. I'm not saying that it didn't help some people, but what I'm saying is it wasn't effective to solve the population-based problem, which was still going up. And so what we did instead was prevent. So those firemen that were coming in afterwards and saving people's lives and rescuing in the most heroic ways, God bless them for doing that, they then became the inspectors that come in and check your fire protection system. They check your fire extinguishers. They make sure you're compliant. And I can remember when I was in school, one of our teachers hearing about these overhead sprinklers and saying, that'll never happen in schools. But yet it's in every single school in the country right now. So there's the reason why we have to be able to address those kinds of things as well. Yeah.
There's a saying that I like, and it's culture eats strategy for lunch. And there's such a culture in our industry, right? That the people wanting to help, hearts are in the right place, money's linked, so it's kind of guiding them, like we just said. If I'm a local emergency management, even a state health department, someone who has a hand in disaster, and I can't wait on Congress to do something at the national level, are there things that they should be considering looking at re-examining as an agency, as a local jurisdiction with their partners?
Yeah, really good question. Actually, that's what we're doing in Fairfax County now. I think, it's a wonderful place to actually do that kind of work. But, we're basically developing community outreach. And what we want to do, we laughingly, but we're serious about it. We want to work ourselves out of a job. We want the community to be involved and have them identifying where the risk factors are. If you live in a small town, the bad side of town, the wrong side of the tracks, you even know the families and what's going on inside of them, where the dads are alcoholics, all the other social problems, that. But those all weigh into whether you're a disaster victim or not too. But you can use that kind of fabric like we did in Puerto Rico after the hurricanes to actually empower people. So we went to Puerto Rico after the Hurricane Maria and met with the local communities themselves, the priests, the mayor, the fishermen's union, and brought them all together and said, hey, man, what happened if we don't wait for the disaster to occur? You guys know when the hurricane's coming. You know when the cone's pointing at Puerto Rico. How about you guys grab grandma and take her to the safe side of the island before the hurricane comes, like 4 to 5 days ahead of time? And they were like, yeah, that's a great idea. It also empowers local people who have a little bit more power and accountability than maybe upstairs, right? FEMA, perhaps, or even the territory. So here they had made this thing, this agreement among themselves. Hey, if this happens and we know it's happening, you have a car. You can go get grandma. You'll take her over to her family over on the other side of the island. That's the kind of grassroots stuff that can be done anywhere. And that's the kind of stuff that I think really does make a difference. Now, of course, it's difficult to scale that in huge cities, but in huge cities, you also have other assets. You have more funding. You have more systems that you can work with. So the bottom line is location, location, location.
You've been a worker. We saw the pictures of you in the field. You've also been a decision maker for departments you've been in. But there's always someone above us that we have to convince to do something big, right? If we want to make a change, we got to make the case to some degree. You have a lot of good data there. And in my experience, I've taken data, and that's a big, right? It's got to be rooted. That's the foundation.
Mm-hmm.
But there's usually something else. And have you found success of what it is, whether it's, one little, hey, let me just try this one as an example first, and then maybe we can scale it? Or is it tying it to funding? What, along with the data, do people need to bring with them to make that change to their leadership?
That's good. That's a really good question, actually. And that's one of the things that I think I learned by doing international work, because going into places that either were committed or not committed, and you can work in one situation and one environment for so long where no one's committed, you think everyone's like that. And it's very refreshing to go into these places and the other places in the world that just experienced a disaster and it's still fresh and hot in their mind. And so they're really ready to go. And so that was one of the things that's really that level of commitment, but not only that level of baseline commitment that occurs at the local level, but also that upper level. So I would say governance is the difference. And if you don't have people that recognize that the primary reason for the state to exist is to protect the people, that's a foundational reason for the state. They call that the duty to protect in the United Nations. And actually, other nations have been criticized by the United States for not protecting their people. Myanmar was a good example during the cyclone. So this issue of actually a human rights, the reason for the state, it's a fundamental issue with it. I don't think we're asking for much. And to be honest with you, I don't think most of the American people would tolerate the fact that we don't follow trends if they knew that kind of thing and they actually know that these things are linked together and that what we're doing is this message. So I say number one is that the governance, you have to have people that are looking for the solution instead of looking for the problem. Mm-hmm. And I think that's number one. And I can roll into places that are completely different than the United States, but if they have a mission, they jump right on it. And I've seen that happen in huge countries and even in small ones. So this happened in the Republic of Palau. They have 15,000 people in that country. And then there's another country that we did this over a 2-year period, actually trained them where they in public health, they knew nothing about emergencies. And then we did the plans for the world's largest mass gathering in world history, 70 million visitors in 6 months. And this group knew nothing about emergency preparedness response ahead of time. And where was that? China. So it can be scaled up in all different kinds of ways, but the real issue is starting to think about risk upstream instead of a response downstream. And actually, that's where the challenge lies. But think about it. We didn't even used to do this. I had a boss at CDC, good old Kent Gray. I can remember Miguel and I both know him so well. Good old Kent Gray said, Keim, no one's ever going to do preparedness. I was like, are you kidding me, Kent? Well, that's where we are today. No one's ever going to do prevention, but I would pose to you and the people in this room that actually prevention is public health. And actually, you pick up a book on public health and open up the first chapter, the first page, it'll tell you public health is prevention. And the rest of it is medicine. That's cure. And when we put these things together, that's the role of Public Health 3.0. We are the convener, we're the catalyst, we're the glue and the grease to make it happen in the community. But we can't drive this. We're not the answer. The answer is the population themselves.
Mm-hmm. The governance, adding something on that resonated with me when you said that too, because when I've gone in and helped affect change at certain organizations, before the strategic plan, before the change management, you often start with governance. How are you all making decisions as a group, right? And you have to agree upon, is it going to be a structure where we're making it as a group? Are we going to root it in data and getting your team to get the governance within your organization agreed upon and formalizing that we need to maybe rethink how we're making decisions and agree upon how we're doing that, because it's going to lead to better decisions. Oh, I just lost a thread in my head. When one of the things in public health, it's this weird dichotomy, and we see everyone in the field sees it, where it's really tangible to see a disaster, right? And see the response, and there's images, and there's a lot easier measurable outcomes that aren't longitudinal. Like you can see them right there. How do we what are effective strategies that you've seen to get some of the public on board with the prevention, with the mitigation? We're going to use some of this money towards then, but you don't necessarily get to see the photos of those benefits as easily. It's really hard to celebrate something that didn't occur, that whole side of it. Do you have any experience with that, recommendations, and how we communicate some of this to the public too? Because we need their buy-in at some point.
Absolutely. Good questions, dude. So first off is that I think we have to just take it and go back to being public health. We're all talking about ICS like we're a bunch of FEMA folks, and we're all doing emergency management language. And I love that, but that's not all public health emergency preparedness and response. Actually, emergency preparedness and response kind of assumes that you have an emergency that you're preparing for the inevitable and then going to respond to, instead of saying emergency health, which I like to promote, which basically says, hey, let's stay healthy regardless of the hazards that occur. How can we protect health proactively? So just switching gears on that piece, I think, is part of it. But I think, what you're asking for is more of the strategy or the tactics for that. I think getting back to the good old basics of public health, we do that. We've done that with tobacco. We've done that with automobiles. We've done it with narcotics. We've done it with a lot of different things that are hazards in society. It's being able to take a public health approach and put public health in the driver's seat. But I think what happened is just by the funding and the development of our field, it started off in emergency management. Of course it did. It started off as the Stafford Act, and there was no public health component. It was only after bioterrorism that public health started really stepping up and getting involved, and we were stepping into the FEMA model for incident command and reaction. But what we didn't bring to the table were thinkers in public health that took public health there. So preventing exposures, lowering the vulnerability. In other words, prevention of the social determinants of health, protecting people from the hazards themselves, promoting health, because people don't die in disasters. If you, at least the healthy people die less in disasters. And then the other, just removing the hazardous exposures like we've been doing in occupational safety, health. Your electrical plugs in your house are a result of that function. So I think going in that way where public health takes this on as their responsibility to actually lower disaster risk reduction, I think that's one of the fundamental issues that we're missing. And so once again, it's a matter of actually just doing public health and actually augment this response capability that public health, it's not our primary responsibility. And a good example was COVID, where now we mix and match those things back and forth without really evidence base in some of those things. And it was remarkable how far we got out from that. And in the meantime, a lot of my friends that are emergency managers, I speak at IEM all the time. A lot of my friends that are emergency managers are saying, hey guys, where are we in this deal? How did we get left out? And so, yeah, it's a long way to go. But I think the issue is once again, we have to have people that are the champions in this, just the same as there are people right now champions for chronic disease and autism.
Mm-hmm. Yeah. I like your parallels. We like to think everything sometimes is unique when we approach it, but we've done it in public health. It's just another issue of delaying long-term consequences, right? And how do you change that behavior, that gap there?
Yeah. And you can't preach to people. You can't force them into it. But actually, you know what? Frieden's pyramid, Tom Frieden was the director of CDC at one point in time. He did an article where he talked about the pyramid, the public health pyramid. And at the top of the pyramid were the easy things to do. And the bottom of the pyramid was the more difficult things to do. And at the top of the pyramid are the most ineffective things to do. And the bottom of it was the most effective. And the top of it, the most ineffective, but the easiest to do, is to train and teach and have conferences. And we teach everything we want to hear because we sound so smart. We got our cape on. I'm a professor. Look at me. But what it doesn't do is empower people in the periphery. And when you get down to the bottom of that, the pyramid, Frieden's public health pyramid for all diseases, all injuries, the bottom is socioeconomic status. And when you make changes in that, you make changes in health that are long-standing, permanent structures. And that's how we get things done. We don't patch it. We don't promote it by putting a Band-Aid on it. I'm an ER doc by training. I will always be that by my heart. But I can tell you the answer is not in the emergency department.
You've been carrying this flag for a while, Mark, and I know you're going to continue to carry it even with the turbulent times on our landscape. How can we follow that journey? How can we support it on a national level?
Yeah, a couple of different things. One of them is just spread the word, share this information. I don't think it's actually been well socialized. There's a few resources out there, but not many, and not many of them that we're looking at. So one of them, I think, is recognizing that the United Nations has an international strategy for disaster reduction. The other is the framework for disaster reduction that the United States signed on. So it tells us, yeah, we have been doing this for a while, and there's a larger world framework. The second thing that I think people can do is to learn more about prevention itself. And many of us have come into these emergency fields without knowing public health in general. Open your eyes, look around to what other folks are doing as well. And then I think the third thing that we can do is also start thinking about what the victim's perspective is. And I think that that's one of the things that really helped me is that when I went into these places, man, you look in people's eyes, you actually get an opportunity to see disaster victims. You see the same problems over and over and over again. But, some of the places where they solved it were places that had the average income was like $5,000 a year. People solve these problems without a lot of technology. And I noticed in the comments that when Pat Frost says we rely on tech for all solutions, but tech will always fail in disasters when lifelines collapse. That's it, right? So man-made tech is not going to be the answer. What's the answer? It's your neighbors, it's your bro, it's your friends, it's the people that are around you, and your commitment at that local level. And that's something that we don't necessarily always need federal assistance on, but we certainly do need more help on. So I think that that's one of the things. The other thing that people can do as a resource, looking as a resource, let me just plug my book. So I just wrote a book on emergency health that's published by the American Public Health Association that describes all these things. I define the 4 pillars of emergency health as being prevention of the social determinants, protection of people from the hazards, health promotion so they'll be healthier, and then finally, if all that doesn't work, provision of care and medical care and shelter and the things that we can do. A comprehensive system of upstream and downstream. I encourage you to take a look at that. It's in soft cover as well as also it's online. But that's kind of my first opportunity during COVID, actually, to sit down and just get that all out in one comprehensive plan that goes from the beginning of what is disease, what are injuries, what are the causes to disasters, and then what can we do about it in a more preventive ways. Thanks for putting that in, by the way, Drew.
Yeah.
But yeah, the bottom line is that there's just like a rock and roll. There's no money in it now, so it's just like publishing. All I can do is turn to people and say, "This is what I'm talking about when I'm talking about these big ideas." There's something where you can go and get more detail. So,
awesome.
Yeah. And in the meantime, if you buy it, I'll make almost $1, so it's great.
Which, if you save up, maybe you can get a new internet provider in 10 years.
I'll buy another tornado book.
There you go. Thank you, Mark. Mark's on LinkedIn. I'll share that here too shortly in this chat. If you want to connect on there, I appreciate you sharing this. This is super exciting. As a public health background who got into disasters, I follow your train of thought, and there's an opportunity here with every crisis. I always think there's an opportunity, and it might be a longer one. This isn't going to happen overnight without, especially Congress legislation. But it's one thing I think we all need to start picking up that flag and carrying it together, because it's the one that's going to lead to the most meaningful outcome. So thank you, Mark, for making time, sharing it with us. Really, really appreciate it.
Hey, thanks, man. I appreciate it. And everybody here, keep up the good work, folks. They can kill us, they can't eat us. So keep up the good work, man. I'm telling you, stay with it, because this is all going to change. I've seen it go up and down 5 times in my career. So stay with it.